Okay. All right. So we are at the last leg of our question and answer period. I want to thank our speakers for getting back on. I especially want to thank my partner here, Miguel Martinez, which was Lillian's name until a couple minutes ago. Miguel managed to put all this together through traffic jams and internet flubs and things like that, but it got done. So thank you. And thank you also to Mandy Kaplan, our GW marketing director. Special shout out to Kim Kempton and Greg Bloom, who are on for all the preparation. You think this happens in one day, but it takes weeks and weeks. So thank you. And thank you to everyone out there in TV land. The numbers were amazing throughout the whole day. And as I see them rising now, that means that people want to hear this being live. I wore the same suit that I had on when I did my administrative roundtable to trick people to think that was live, but I don't think it worked. One of the questions that I got throughout the day was, will we be sending out slides and things like that? The answer is yes. We're also going to post this up on YouTube, so you're all going to be famous. All right. So if you're out there and you want to ask questions, Miguel will be following the dialogue box. Speakers, you're not allowed to ask questions because I can't keep track of that, but everyone else can. And speakers, you're all experts in your area. So if you want to talk to each other, you can definitely do that. Do it and argue with each other. It'll make it more dramatic, and then I can stop talking and listen. I'm going to ask the panelists questions in order of their presentations. I'm going to break that rule right at the outset, because during a lot of the sessions, technology was mentioned and it was a theme. So I'm going to ask Nelson Gomes, who is the Senior Vice President of Business Development for Medicus IT, a question that I think is on a lot of people's minds. And that is, Nelson, for ASCs in particular, but healthcare entities in general, what is new technology that's coming down the pike that people should be paying attention to?
Hi, everybody. Thanks for the invite, Andrew. And yeah, I think that there's kind of 6 different areas I would say there was a focus on. I think that security always continues to be top of mind for everybody. More than ever, healthcare continues to be a primary target for cyber criminals. You know, if they can monetize it, they're going to continue to do it. We're seeing that more than ever before. And unfortunately, it's just not the big hospital systems that they're after. If they can go after a bunch of small practices which are easy targets, they're going to do it too. Money is money. We're seeing a lot of that happen, and we're advising our clients to really focus on being preventative as best they can. We're using some technology that's out there that can keep them secure. But more importantly, is about training and really providing some awareness to the employees about what they should be looking for. Because that's your biggest, I would say, armor against cyber criminals, is to really educate your team. I think that some of the other things that we feel are going to be important, not just in the ASC but also in practice, is focus on aligning the clinical with technology, the clinical workflow with technology to improve efficiencies. I think we saw a lot of that during COVID, right? So how were people, how were doctors and administrators able to communicate better with their patients from the time that they set their appointment to the time that they came into the office, and in between, right? Being able to park in the parking lot, wait to get called into. So that whole experience, the patient engagement has, COVID has really changed it, and we're seeing a lot more investment in that patient engagement. So I think that's going to be a big piece of what we're going to see in the future. With that, we're seeing remote patient monitoring as being a big part of it. And I think it has to do a lot of different areas. value-based care has a lot to do with that as well, and I'll get into that here in a few minutes. But remote patient monitoring, we're seeing more and more practices, especially that are doing more family practice, that are taking certain monitoring systems back home, and they're being monitored, and then that's going back into the patient record, and doctors and nurses and the clinical staff are able to see the progress of that patient. And more importantly, the practice is getting reimbursed for that. So patient engagement, I see, and we're seeing in the industry that it's really quickly growing. We heard during today's several presentations about value-based care and how that continues to drive a lot of practices into that model, and data really is the driving factor there. So data analytics from the clinical side and the financial side, you're going to see a lot of those type of systems that are going to be able to pull that information to be able to do that reporting that you really need to get into, that analytical reporting, which then leads to business analytics. There's a lot of platforms already out there that is taking the data out of the EHRs and the practice management systems, and they're providing those key clinical and financial performance indicators in a dashboard type of format, so that they can see how the performance of certain areas within the practice and within those ASCs are working. So those are, I would say, the top things that I feel that are going to be a focus in the future of not only in the ASC market, but as well as in the practice.
All right, thank you, Nelson. For those people who are listening to the administrators panel, Lily made a good point about doing risk assessments. So you should go back and listen to that, because I'm afraid that there are too many providers who are not doing that. All right, so now let's go to the agenda. Greg Bloom, my partner in crime, you have been doing the State of the Union. I know we had some technical difficulty on the New Jersey Association president, but you've been doing it for many years, and I kind of reflecting for 8 years actually. So reflecting back on the 8 years, I'd wonder if you could share with us how you think things are changing, and in the next 12 years from the regulatory perspective in general, where do you see things going?
Thanks, Andrew. So I'm not going to go back 8 years, although yes, I have been doing this session for 8 years, and thank our regulators and leaders for doing that with us. But over the past year or so, I think ASCs became an even more integral part of the healthcare system. In some ways, I think COVID helped that, and for certain procedures in particular, people saw that ASCs became a very safe alternative to going to a hospital where you may have a potentially infectious patient population. So I think that helped over the last year. That said, and as we heard from our leaders, the regulatory limitations continue to make the expansion of ASC operations difficult. And that's not to say that some of these regulations don't have important goals, like COVID testing, for instance, over the past year, but it just requires a lot of effort for our ASCs. As to where they're going in the future, based upon what I've heard from all of our association leaders, I think that the regulatory framework for ASCs is going to continue to be a battle. But hopefully people out there are seeing, how well the ASCs performed throughout this pandemic, and that they'll recognize the importance of ASCs in the healthcare system, in keeping with our 8 years of panel. And because of those battles, I think this could be a good time for advocacy from our leaders to point out how great ASCs performed in this period, so that they can operate even more efficiently and effectively in the future.
Thank you. I agree. I was particularly disappointed in some of the things that, not the way he said it, but in Bill Prentice's reporting, that it looks like the Biden administration is rolling back some reimbursement issues. So hopefully they can push back and make that not happen. But yeah, all right, keeping the battle going. So Doria Cipriani, so your OSHA compliance presentation scared me.
Oh,
No, it's okay. I don't have to be fit tested, so it didn't scare me that way, but scared me from my clients. And one of the things that a lot of clients, because we have clients that are getting whacked by, audits for fit testing and stuff like that. And the question I get, and I'm curious about how you answer it, is when I sit down with a client and I show them, you had the same slide I have, which shows all of these scary penalties that OSHA can hit you with. They say to me, but that's not really real, right? Like that's just, they put that in there to get your attention and they're not really going to fine me like hundreds of thousands of dollars, are they? What would you say to that client?
I'd say they sure are. Absolutely. Thanks, Andrew. So it's really real. It's not for shock value. OSHA has a well-established program of imposing fines. They have, a minimum and a maximum based on the type of violation, its severity, its frequency, whether or not have fixed it, it's been cited before, and they have a plan on how they're going to get their money. And all the funds that are received go right to the U.S. Treasury. So it is absolutely real.
Yeah, and I think especially as the government seems to be every day looking for money to pay for the new spending packages, that might be a way to get some. Okay, we're gonna do like speed dating, speed questions. Ready? I get this question all the time too. Do all staff have to wear a respirator mask?
Only if, no, they don't. You want to check your policies that were created based on the hazards identified in your center, in your space. And if your policy says that they work in an area that requires it, then yes, they should be wearing it.
Okay, I get this question. I have a really experienced tech that wants to do fit testing. Can that, is that okay?
So the fit testing is usually performed by the RN on site, the director of nursing. They're trained to do that, or the vendor, third-party vendor, the OC Health provider.
Okay, so by the way, if you're wondering, if you are out there and I see our numbers are rising, if you're wondering what a fit test is, you are seriously behind the 8 ball, but but maybe because somebody just said, what is a fit test out there in TV land? So why don't you give it 10 seconds? Because they obviously did not listen to your presentation, but what is a fit test?
The respirator, the mask that goes over your nose and your mouth, it has to fit you properly, has to fit one properly. So there's a test that's performed, spritz of some saccharine-like substance in that format, and you're testing that the fit is proper and that you'll be kept safe.
And so if
Andrew, can I jump in for a
please,
question on that? Because I've had doctors ask me on the fit testing, doctors with beards, I've heard of pushing back because you can't do a proper test on someone with a beard. Have you experienced that, Doria?
So it's the facial hair, absolutely. It's the facial hair. So in this environment, we've kind of worked around that a little bit. There are other ways to do a seal check, and the traditional N95 tight fitting mask, if that's absolutely not getting a tight fitting seal because of the facial hair, then they have to look at an alternative, perhaps a PAP or one of those space kind of looking hoods for an alternative, because you need to have that good fit.
Wow.
Thanks.
Okay. That good question. And if I do that test once, am I done? That's it? I did it 2 years ago and I'm good to go?
No, annually, you have to do it every year. And if you change the type of mask that's being used, or if you gain a lot of weight or lose a lot of weight, it has to be repeated. Okay.
And we have a client that swears they did those tests, but have no records to prove it.
And then OSHA's going to say, okay, get your checkbook out because I'm going to cite you, and you have to have it documented.
Right. The good news is that they hired incredible lawyers and will somehow hope they're not listening, but we'll find a way out of that. Okay, last question for you. You mentioned Ppe surveillance audits. Like how many should I do and what should I be doing on that?
So there's no magic number out there that's going to be in any document. It has to be meaningful, and quality driven. You want to be sure that you're capturing all your end users, observing all of your end users, your nurses, your techs, your docs, your anesthesiologists in all their areas. If you survey them, observe them quarterly, by the time you do all of those things, see all your users and see them in all their spaces, you'll have a quality driven, meaningful amount of observations.
Okay, so I'm gonna go and pick on Danielio for a second. Well, actually, no, I'm not gonna pick on you because I'm gonna pick on you on something else. Lillian and Monica, I mean, are your I want to ask you about yours. Is your theoretic ASC out there or your average ASC, are they OSHA ready?
Yes,
Yeah?
yes,
Okay.
they are.
Okay, Monica is thinking about how to answer this politically. Let's say there's room for improvement, right? Yeah, you're on mute. You're still on mute. Okay, we'll come back to you when we'll get that off.
Bottom left.
There we are. Good.
There's opportunities for improvement.
Yeah, okay. All right, let's move on to HR. We got a lot of questions, a lot of good feedback on that. Obviously had a lot to do with Marianne and nothing to do with Sal Puccio, my two partners who presented that. So, I mean, people are a little bit tensed out and stressed, and I think that's producing a lot of HR issues. But the question that I'm getting almost on a nightly basis, and I don't know where we are. I think, Marianne, the answer could change tomorrow, but where we are right now at 3:48, where are we on this religious exemption mandate from the federal government?
Okay, so hi, everybody. So there was an oral argument on some of these pending litigations just yesterday afternoon. And they heard the issue of the religious accommodation. And it was interesting. I mean, the court did, note that you have the Title VII federal law, and they were addressing the issue of preemption, right? Does the federal law preempt the states from implementing like a public health type of mandate? And one of the judges noted, like, look, Title VII hasn't been used to preempt a public health mandate. So there seemed to be some, in our opinion, understanding that in times like this, the state should be able to implement something that is stricter than federal law or override or preempt the federal. But I mean, there's been no determination as of today. What we did find really interesting, and Sal and I were talking about it, is I don't know if this was just a, let me cover all my bases argument from the state, but at one point during the argument, the state said, well, the mandate, while it doesn't have the language about a religious exemption, we never really said, and this is me paraphrasing, that you shouldn't consider religious exemptions. That Title VII, they should still take the religious exemptions and consider them. So I thought that was a little interesting, a little bit contrary to the prior arguments. Maybe it was a way to make sure that the law was not totally invalidated, and we'll have to wait for the decision and see how that comes out. But it certainly was a different stance than we had heard earlier. And I just want to also mention, as far as an update, I have to talk more about the case law, but people keep on asking us, is there anything new out there on the federal mandate, 100 or more employees? Do we have to start implementing or the testing? And as of maybe an hour and a half ago, I checked online, there's still no regulations out there from OSHA as far as the implementation of the federal mandate that everybody's kind of waiting on, and whether or not the cost of the testing is going to be borne by the employers. They're going to have time off to go get this testing done. Those are still unanswered questions as of today, Andrew.
Okay, so if you're watching this on YouTube land, it's not today, so it may not be right. Okay, so Sal, when we were doing our administrative roundtable, so people are tensed out, okay, as I said before. Let's say a doctor, of course, not at any center we represent, but let's say theoretically, a doctor has a kind of a hostile interaction with a nurse, okay? In part of your discipline of that, can you take into account, the times that we're living in? Do you get not a mulligan for golf people, but do you get a little bit more leniency, or is it, no, I mean, hostile is hostile?
Thank you, Andrew. Thank you, everyone, for participating today. I think the times we're living in do require a little bit of more case-by-case analysis. And generally speaking, any incident that you have in the HR world that's going to create some type of complaint or hostile situation really does need to be vetted on a case-by-case basis to determine the individual prior history. And that's probably where I'd start and look to go see, was this a one-time isolated incident where this doctor maybe acted a little inappropriately, flew off the handle a bit, but it was completely out of character? Or is this a person who has consistently demonstrated behavior of acting hostile towards other individuals? And I think it was within the last week, I received a call just very, very similar to this fact pattern. And we said, well, see what's going on, talk to the doctor. It was an overreaction. He apologized. We were able to move forward with staff, explain the situation, and it was resolved in short shift. So I think that would be the best way to do it. Keep in mind the history, most importantly. And it's not excusable. It still warrants a bit of a reprimand, note to file, but I don't think we have to go nuclear, so to speak, and start letting everybody go.
Okay.
Andrew, can I just add a little bit to that
Please.
as well? So, we're also getting comments or clients that are talking about, well, people aren't doing their performance or not performing well, and they're just blanketly saying, well, given the pandemic and my mental health, right, that's the excuse they're giving for not performing well, right? And so you really have to make sure you flush that out a little bit, at least a little bit, and make sure it's not a true disability issue where you have to engage in the dialogue about reasonable accommodations and kind of confirm that it's their mental health or stress or being overwhelmed just in general is not, preventing them or impairing them from doing their job. So it's a little off topic from what you said, but it does come up in conversations with regard to performance and discipline.
Yeah, it's a good point, and we'll have to consider Greg Bloom's issue a little bit further on that. Well, okay. So, by the way, the reason I keep looking to my left is there's a screen which the questions that you guys are sending in, keep them coming, but there's no possible way that we can get to all of them, but we, at least now, we'll get to them after the seminar. But somebody asked Marianne, who should keep the vaccination records, the records of vaccinations, and should those be protected?
Okay. So let's go back to it. It's really, I'll start with saying it's a need to know basis. And if you recall at the beginning of the pandemic, when we were talking about, okay, this one tested positive, we got a quarantine, we weren't allowed to give the employee's name. And it's no different with the test results that you're getting for the screening process, right? Just as at the beginning of the pandemic, you sent around a notice that said, okay, someone in the office tested positive, we're doing our contact tracing, nothing has changed here. And so what we really recommend is that if you're doing the testing on site, okay, the person has to be trained to do it, but someone who knows how to keep records confidential. Now, it's not a HIPAA per se, right? If an employee gives you their test results, you're not the provider, right? But you do have to consider it if you're the one actually doing the testing, right? So if you're actually doing the testing and you're getting the results of the testing versus you send it off to the lab and the lab gives the employee the results, okay? The lab gives the employee the results and then the employee voluntarily gives it to you, that's different. That's not gonna, be a HIPAA per se issue. But if you're gonna get the results, you want them to sign some kind of a consent or authorization that you can use the information in connection with employment screening practices. Still, you're not gonna go around and broadcast that. It's gonna be kept on a need-to-know basis. And in my opinion, it's usually HR. It's not going to even necessarily be a direct supervisor or a mid-level or midline supervisor. All the supervisor needs to know is the employee is out. They don't need their COVID status. They're going to be out, and we'll let you know when they're coming back. Unless that supervisor is really involved in contact tracing and, has a need to know basis, we would keep that information confidential. And most likely, within HR or maybe very senior leadership. So I hope that
Okay.
answers the question.
Yeah, it does. And also a lot of ASCs, especially in my experience, especially in the beginning of the pandemic, were doing testing on their employees. So if you did that, that does raise the HIPAA issue that you mentioned. So, okay, one last one for HR, and I know there's a lot of HR questions coming in. Again, impossible to get to everyone. Sal, yes, no, does my ASC need a marijuana policy?
Yes, so I would update it to be consistent with your alcohol policy in terms of what the testing is going to be, because we are seeing employers get in trouble for following old policies and testing for marijuana in the tri-state area improperly.
And should that marijuana be shared with Garfunkel Weil, attorney representing the ASC? That's the
As
real.
long as the attorney is a member of the cannabis group. We had a-
Yeah, that's right. Hey, good plug, Sal, you're
Right,
learning.
we have a good cannabis group. It was a lot
Yes.
of reading and hard work to get in there, but some of us managed to get in. So keep
Yeah.
us informed in terms of all the growing and selling and everything else. We're here for you.
Good plug, good plug. Okay, so Alicia Schickel, I see you there from Garfunkel Health Advisors.
I'm here.
So I listened to your and Michelle Richards' presentation on medical records and efficient coding strategy, and I kept wondering how much effort providers are really putting into both of those. It made me concerned because we're seeing, and I know Deborah Silverman's on the phone, and I'm sure Maxine, we're seeing so much aggressive activity by payers. It's just out of control. I mean, I shouldn't say it that way. It's great for us, bad for the providers. But my question to you, Alicia, as I was listening to this and worrying, on balance, you as a coding expert, been doing it for many years, and you've seen it, I think, before, I don't want to date it, but you've seen it before EMRs were big, and now you've seen EMRs all over. Are EMRs helping this situation or making it worse?
Yeah, so great question. You know, EMRs can be a very powerful tool if they are set up and implemented correctly. Unfortunately, we see a lot of cases across the industry where they also can pose pretty significant risk, right? We see poor implementation, poor education around implementation. Templates are being created. You know, what always goes in isn't what comes out. We see a lot of copy and pasting issues. I mean, we look at thousands of records, right? Documentation while we're doing audits and coding. Yeah, cloning, providers relying on computer-assisted coding software without really having any input in the decision-making. So I think, you know, yes, they can be a powerful tool. I think they're a great warehouse for all of the patient information, but I think used inappropriately, they're also setting providers up to have cases where there is, you know, inadequate documentation and potentially, you know, causing improper payments as well. So.
Okay, well, somebody just asked, I'm not going to say who they are, but that they have never had a medical chart audit in their ASC. Besides calling the GHA, how do they start? Describe a process of how do I get from A, I've never pulled medical records and looked at them, and B, I have. What do I do?
Right. So I think, you know, the key word there is really process, right? Every practice, organization, center should have a process in place. And I think the audit process is applicable across anything that you want to audit within your organization. So the first step is really to perform a risk assessment and analysis. That information is really going to drive your audit work plan. So once you identify what within your practice you need to or want to audit, there are very key elements under that, right? You want to figure out, identify what is the objective and the scope of the review going to be. What is the reason? What are you looking for within that audit? What type of audit? Are you going to do a prospective audit? Are you going to do a retrospective audit? Looking for things like understanding things like what is your sample size going to look like? Are you going to do probe audits? Are you going to do benchmark? Are you going to be doing statistically valid?
Right, but just on the simple, I want to educate my people. I've got 12 providers in my ASC. Can I just pull 3 records from each one prospectively, and you could review them and then train? Is 3 enough to just try to explain to the doctors what they're doing well?
No, normally, you know, a normal sample is really going to be between 10 and 15 records per provider. Is going to give us a good idea for compliance purposes if you have outlier providers, if there are issues. So I think, you know, pulling the data, sample 10 to 15 records per provider. We do the reviews, we come back with reports, we have corrective action if necessary, and then we educate, right? We have one-on-one conversations, we follow up on those reports, and then, you know, we figure out who's an outlier, who did great, when do we need to re-audit. But I think the key is there for documentation and coding reviews, that, you know, an initial benchmark review, 10 to 15 records per provider is sufficient.
Okay. And I know GHA has a program in New York. You have to certify medical records. I'm gonna have somebody with some degree I never heard of sign off on it. I know GHA does that, but actually I never asked Lily and Monica, well, in the other states that you're in outside New York, is there a similar, that you know of, a similar requirement that you have to have somebody certify medical records as, you know, complete, or is that just a New York craziness?
That's New York craziness, Andrew.
Yeah, there's a shot.
Totally.
Yeah, so in the 3 states, yes, and that also falls under, we have yearly audits of medical records driven by the partnership, as well as the accrediting bodies require you to do medical record audits and peer review audits, which are the medical records as well.
Huh.
They
Then-
don't require,
Yeah.
nobody else requires a certified medical record person to audit the medical record. Other
But
than
it's,
me.
but it sounds like it's happening, you're doing it because you think it's a good thing to do. So Daniela, in Connecticut, to your knowledge, are people looking at medical records? Are they trying to assess whether they're doing a good job, or are you just not aware of that?
Yeah, we've always conducted medical record audits, peer review. That's part of the accreditation guidelines as well. Peer review is essential, and we're always checking on a monthly basis.
Okay. All right. So thank you, Alicia. Looks like GHA is going to be busier and busier. Okay. Going on to consolidation in the industry. It's amazing that we can have pandemics, but people are still doing business. And we had Bob Getling, principal with the Bloom organization, and Kim Kempton representing their session. So Bob, let me start with you. Whether it's an ASC or a physician's practice, I decide, you know what, I'm sick and tired of going to cocktail parties where people are sitting there saying how much money they make. What's the first thing? Like, how do I, again, kind of like as I asked Alicia, I want to sell. What's like the first couple of things I should do?
Yeah, that's really easy. Call me. That's the easy answer to that. But on a broader, from a broader perspective, my recommendation always is that it's not a wake up in the morning, you know, I'm deciding to sell my house. It needs to be a process. And always, even if you're, you know, I tell physicians this all the time, and it doesn't matter whether we're talking about their surgery center or their practice. You need to always be looking and always investigating, looking at your market, watching how the health systems are changing, watching how the payers are changing. And if you do that, then you know when the time is going to be right because you've been doing all your homework. And then also you're already in phase one of the process, right? Because while you're doing all that investigating and watching all that stuff, you're also looking at all those factors. How does the monetization work? How does the equity work? All that stuff. And it gives you the head start so that it's not tantamount to waking up in the morning and saying, you know what, I want to sell my house and move to Florida.
Okay, so Kim, you're selling a lot of things. I think the second call after calling Bob should be called GW. But when you get
True.
when you have the providers come, what do you think or can you think of, like, one, a common problem that delays thing, and two, what do you think is most unrealistic about their expectations?
Is that for me or Bob? Sorry.
For you, Kim.
Oh, a common thing that delays things, never the lawyers. Usually what I feel like ends up happening is people are very bullish about their own transaction, and then they jump in, with both feet, and they don't do their homework and they don't plan, like Bob was saying, and that can actually lead, I think, to timing setbacks. And then I forgot the second part of your question.
Yeah. What do you find is the problems? Like, you're looking at a new center. What's a common thing that they're not ready to sell, even though they have mentally ready?
Oh, I see. When they haven't cleaned up their own house, when they're all sort of fighting with each other, and they have all sorts of internal issues, and no one wants to buy a dysfunctional family, let alone be part of one. And when they don't have, normal things like financial statements prepared on a regular basis, and regular board meetings and board minutes, and I think that can really scare off a buyer, as well as if they don't have strong leadership and management that can sort of educate the rest and keep everyone on track.
Bob, do you agree with that?
Yeah, I mean, absolutely. In fact, I would go as to what Kim, Greg, and you have all seen, and myself over the years, that having the financial statements, having a good, administrator talking about an ASC, the same holds for a practice. You need a lot more sophistication than that today. I mean, the transactions now, the joint parties with hospital systems and payers and everything, the sophisticated private equity, the sophistication has gotten so much higher that this is not the old days where you call, AmSurge, and here's their model and here's how they do it. There's so much more to it now that you really do need the advisors and the attorneys, like you guys that do nothing but these types of deals, because you can't, the brother-in-law divorce attorney coming in on trying to do one of these deals is, it was a nightmare 10 years ago. It's a disaster today.
Right. I hear it. So let me ask you, you mentioned private equity. So we have a lot of doctors coming to us and they say, we're selling our center for $80 million. The second question I ask is, that's $80 million in cash? And more, it's no, it's $40 million in cash, and $40 million plus dollars in stock in the MSO that exists or to be set up. And I think the doctors, at least early on, they see them as equivalent. Are they equivalent? What should they be thinking? And what do you see kind of changing in their thinking as we go through the transaction?
Yeah, so I'll answer that in reverse order. What should they see? What do they see at the beginning? So using your example of an $80 million valuation, 9 times out of 10 at the beginning, the physicians are like, get me as much cash and as little of the stock, because that stock isn't worth anything. I want to maximize the cash. That's what they always say at the beginning. And again, going back to what I said earlier, that it's got to always be a process, an education process going through this. That's the way it starts. Again, 9 times out of 10, by the time it ends, the physicians having gone through the process and understanding the way the transaction works and understanding the way private equity, they're like, well, we want to get us more of the equity, because they see that they have the investment, not only the monetization opportunity, but the investment opportunity on that. So, it'll start where they don't appreciate it. And, I want cash. And again, that not appreciating is perfectly normal, because if you remember, sorry, Kim, you probably don't, but Greg and Andrew, you guys might remember from back in the 90s when all those physicians sold their practices for stock. And, they wanted to work for $100,000 a year, but give me more stock because I'm going to, make a killing on it. When all those companies went into the toilet and the stock was worth nothing, it was an implosion and it didn't work. And so now, there's it's perfectly normal for physicians to start with the idea, the stock isn't worth anything, I want cash. But if they properly go through the process and all the steps and get educated, then they're in a much better position towards the end to make a decision on how much equity. And that differs based on their age, how much longer they're going to practice, what the particular partner that's buying them, what their financial situation looks like, and so you have the not only the monetization but also the the investment, the betting on Facebook or Google type of an investment.
And you're this, and then I'm going to move on, but I'm fascinated by this second bite, which everyone doctor starts talking about, that then they'll sell it, and you've alluded to it, so they call it the second bite. Have you been involved in an increasing number of those second bites? Like, when are we going to see those happening? We're doing a lot of transactions, but I'm not seeing a lot of second bites yet. Are you?
Oh yeah, because again, the typical from a private equity perspective on getting in and then getting out, they like, you like to say it's 5 years. Sometimes it can be, way more and it never happens, and sometimes a little bit less. But so we've been doing this now long enough to where the 5 years are coming around, and there are some second bites. And we're seeing some extremely happy physicians on the second bite. And to a point, just as a general way of looking at it, when it's done right and the whole private equity model works, the physicians on their second bite will actually take more, we always call it taking chips off the table. They can actually get more chips off the table on that second bite than they did even on the first. And still having some equity. But again, you can sit around like I do and tell the success stories, but then there's a lot of, on the other side, of stories that are 6 years, 7 years, 8 years, into it, and there's no second bite, even on the immediate horizon.
Okay.
I have a quick follow-up for you,
Sure.
Bob. When the second bite transactions that you've seen, how are they typically structured? And are the doctors basically able to pull all their cash out, or are they then rolling over into more equity and waiting for a third bite?
Yeah, it's the latter. And when you say how are they structured, it's kind of all over the board. What we try to really push is that equity that they're getting is pari passu with the same equity, and not some lower class of equity as the private equity or whoever is doing it. So we try to push that and make sure that it is pari passu with them. And there's that's a very complicated, it's a very complicated part of the transaction to figure out what is that value, how does it work. A lot of the times the private equity firms will have stuff called waterfalls for priority on when a sale is made, who gets their money first. And so there's a whole lot of things that are variables when they're to negotiate when you're doing one of those, when you're a physician doing one of those transactions.
Okay. Kim Kempton and Bob Gelling from the Bloom Organization. Thank you. Okay. So Lillian and Monica, during your session, I had an administrator text me, how depressing, how long does it take to become a lawyer? I said, that's even more depressing. But we just got a question. It's interesting. The person probably didn't listen to what we're saying, because Monica, I know you spoke about this, but I'll throw it out there again. Wanted to know what considerations are there for RN recruitments out of the US? So I know you spoke about that, but can you speak about that again?
I spoke about it very retrospectively. I know that many years ago in the late 80s, early 90s, I was in a hospital and the hospital went abroad to get nurses. And when they brought the nurses back, the language barrier was so great between the recruits and the existing staff that it was almost impossible to overcome. And the recruits became frustrated because they couldn't learn fast enough, they couldn't understand. And the staff on site became frustrated because they could not recruit. Because they could not communicate. So it becomes a real patient safety issue if you cannot understand and communicate effectively together.
All right, I hear you. Okay. Lillian, so for those stressed out administrators, I know there's no there may be a magic pill, but I'm not a doctor, so I can't prescribe that. But what can we tell them about how to cope, through these times?
We talked about that when we did our prep sessions, and I think it's important that they know that they're not out there alone, and to take a step back and really look at things differently, how they're dealing with it. Think about, we all went into Zoom meetings, from in-person meetings to Zoom meetings, and suddenly work was in your home. It was in your office, in your living room, wherever your office was set up in your home. So those lines are blurred. So I think it's important for them to establish boundaries and to know what their resources are, and to try to look at what's out there a little differently than they've had to prior.
Okay, let me stay with you. I'm going to ask you a question and then ask Monica the same question. So if you had a magic wand and could change, and by the way, we had regulators from several states that listened to the presentations. If you could say to a regulator, I will please change this one thing to make life easier, what would it be?
Well, I am a surveyor as well, so I do see it from both sides. But I think that if you have clear, concise set of specific instructions to tell your centers how to adhere to the standards, and it's not a bias based on who the surveyor is, I think it just makes it, the goals and what they have to obtain is clearer, and so that there's no guesswork.
So you'd want more objectivity. Yeah.
That's correct.
Yeah, I hear you. We've had we've had surveyors taking opposite positions on the same issue. It's very different. Yeah, I hear it. Okay, Monica, same question. What could we change?
I would say fairness and the elimination of disparity between ASCs and hospital outpatient departments and even hospitals. And I related that even beyond the regulators, the payments are there's such a disparity there. And employers are protected too. In other words, so many of the laws are protecting the employees, which is really great. But if you follow all the rules and the employee breaks one and they are terminated or whatever, the employee is still the one holding the bag a lot of times. Like, oh, well, even though I did everything right, somehow I'm still wrong. So I think that's a very unfair way to look at things. And then I also think that physicians, there needs to be some flexibility with physicians in some cases, that they be allowed to come to ASCs for ASC appropriate cases, even though they're employed by a hospital. So I think that there's just a lot of fairness that could.
Oh, you mean when they're employed and they say, now you got to cut off this particular AC and go to ours. Yeah, I hear you. There might be some legal things about that too. I hear you. Well, Marianne and Sal are doing the happy dance because they're kind of agreeing with you. Okay, so one of the presentations that surprised me the most, Daniela, was yours on 23-hour program, 23-hour stays. I had just had never contemplated it. And what I found really, and I thank you for being so open, I couldn't believe, I think it was in the first year, I think it was 2019 of your program in Connecticut, the revenue that Bob, listen to this one. The revenue that they got from the 23-hour stay was, I think, 160% increase. Am I correct? What'd you say?
It was, yes, it was over the outpatient.
Right.
And
That's
there's a caveat to that. It can be, that could be a contribution from payer mix. I mean, certainly we did, I don't have the numbers in front of me, I'm sorry, but we did more in 23-hour stay patients than we did outpatient in 2019 because we were just starting our total joint program. But I think in 2019 specifically for our center, their payer mix needs to be considered because we were.
But a couple of ASCs text me, they want to hire you because they were amazed by your success. But I'm going to challenge you because you were also very frank that you could stay 23 hours, but you're not getting any reimbursement change for that. You're going to have increased expenses, food, you got to have anesthesia staying there. It seemed like such a hassle. And I think you said you're only doing about 3 a night, right? So is it worth it in the end?
I think for an ASC that has the volume and the physicians to, get behind it, it can be worth it. It's the increased revenue is tied to growth. So you're growing to essentially you're adding another revenue center. If you separate your total joints between outpatient and 23-hour stay. But for Danbury, it allowed us to essentially double the amount of cases we were doing in one day.
Wow. So do you know other states that have allowed this?
I know Connecticut, New Jersey, and New York certainly do. I've read articles in both Becker's and AORN that show that I think a majority of the states allow it in one form or another. Some, the 23-hour and 59-minute, length of time. There's other states that allow even 48 and up to 72 hours.
Wow. So Lillian, you have so many ASCs. Are any of you doing 23-hour stays? You're on mute.
Yeah, sorry. We do have several centers that have that capability. Usually the inclusion/exclusion criteria for the patients, the algorithm is that they don't end up staying, but we have the same restrictions in all 3, states and all of our centers. What was mentioned, the 23-hour, 59-minute rule. Our one orthopedic center that's all orthopedics and does joints and spines. We do have very nice 23-hour rooms set up, but we have not had to use them, and they're a very busy center. It depends on the timing of those patients too. We try to bring them in early, and they spend the majority of the day there, and then they're able to be discharged.
Right. Okay. Daniela, last prediction question. Are we going to have more in, let's say, the next 2 years, more joint replacements happening in 23 hours?
I don't think in the 23-hour stay. Certainly there's a shift in total joint replacement to the ASC. Outpatient costs roughly half of what as much as an inpatient joint. But the trend is that outpatient joints are increasing and moving towards the ASC. I think 2020 there were 32% of all outpatient joints were done, or excuse me, all 32% of total joint replacements were done nationally were done outpatient.
Well, talking about the price differential, that's a good segue to Max Reibold and Deborah Silverman on the keys to successful payer contracting. Let me pick up with what you just said, Daniela. So I'll start with Deb. Deb, I'm hearing rumors, but I'm not as out there as you and Max are, that some payers are just saying, we're not going to end up paying this. We're not going to do X, Y, and Z procedures anymore in a hospital setting. We want them to go to an ASC. Or have you heard that, or can you respond to that?
Sure. Essentially, that is the subject of probably the greatest fight or tension in managed care right now, because the plans are looking to push, and they're doing it vis-a-vis policies, procedures out of hospital-based facilities and moving them over to freestanding ASCs. So the ASCs are the new darling of managed care companies today. What I warn ASCs about is today, you're the flavor of the month, but who knows, in a year or 2 years, will the plans try to push those services out of ASCs and into office-based surgeries, hospital or doctor's offices.
It's funny you say that. When we were preparing for this, I clicked on the wrong link, and I was listening to something from about 3 years ago where I made the comment that or maybe it was 4 years ago, more and more hospitals are investing and owning in ASCs, and now that seems like a joke because it's in every ASC practically. But let me go to you, Max. So when Bob was doing his presentation on consolidations, he drew a distinction, which I found interesting, that on a value-based care, that the West Coast seems to be so much more advanced, almost entirely like that, as the East Coast. Do you agree that it's as prominent? Do you see a difference? And do you think that that if there is a difference, it's going to come east?
Well, Andrew, there's definitely a difference. There always has been. The West Coast has always been, call it what you like, a little further along. I don't know if the word's progressive or not in this case, but nonetheless, that has always been the case. And I think it's true today. Now, is it the pervasive model of reimbursement both now and even into the future? I think that's where the jury's still out. I live in Atlanta, home of our National League champion Atlanta Braves, by the way, and we are not experiencing much in the way of that sort of interest from the commercial payers, and haven't for years. Our practice at Coker Group works through and extends throughout the country, including the West Coast. And clearly there is more interest there, but I don't see it being, as I said, just the pervasive method at this point, nor do I see it in the near term, whatever that means, future. It's just what I see.
So when you say that, you mean you don't see it coming east necessarily?
Well, yeah, I think it will ever so slowly. I mean, when you stop and consider value-based reimbursement, we've been involved as an advisory firm in it since March of 2010, which is when the Affordable Care Act was actually passed. And as you know, that has progressed ever so slowly. And, I think the government has made attempts to advance it clearly with various forms and incentives and whatnot, but has it really caught on? No. And will it catch on as it goes west to east? Yes, more so. But again, I guess I look at it in terms of the big circle here and the total pie, and I just haven't seen it yet, west or east, as far as that goes.
Okay. Deb, we have, as you know, we have ASCs that are being audited right and left and fighting with payers. I know you can always sue, and that's when you get a Sal Puccio involved and something like that. But are there other alternatives besides just getting in the ring and getting in front of a judge?
Especially in New York, where there are prompt pay laws out there and a method through the Department of Financial Services. It's very easy. You can go online and issue complaints to DFS. My advice is to issue them one at a time. I know it's time consuming, but drip, drip, drip to the plans. They hate these violations. And if you issue a spreadsheet saying we've been underpaid for 100 claims, that's one violation. If you do it a claim at a time, it's 100 violations, and they get assessed, the plans get assessed, on terms of the number of violations. So what I would recommend is if you really have a pattern and practice of not getting paid properly and you're getting nowhere with the plan or through your plan rep, if you're in New York, start dumping about 3 or 4 of those complaints a day, and you'll be surprised at how quickly you will get some attention from the plan.
It's not just New York. Many states have prompt pay laws, so you
Correct.
can use them. Okay, so first of all, also, Max, as a Yankee fan, I would be remiss if I didn't say I'm rooting for you guys because I hate cheating. And if there's anybody from Houston on the panel, so what?
I'm with you there,
Okay.
Andrew. Thank you.
Okay, well, actually, one last question for both of you. When is it that fine? I've got a request A and request B. Is every request I get from a payer time to call Garfunkel or call GHA? Is that, or is it sometimes they're just routine? How do you know the difference? I guess is what I'm trying to get at. Deb?
You want to take that, Deb?
I'll take it. So the first thing is you get let's say the first request is they want to look at your medical records. You don't have to run and call Garfunkel at that point or call Max at that point, but make sure you comply with the request, make copies of what they're requesting, and then do your own internal investigation. In looking at that internal investigation, if you see irregularities, that's when it's time to call Garfunkel, GHA, Coker, just to make sure that, okay, I want to be prepared. Because if you do spot issues and mitigate before they even come back to you and saying, hey, dear facility, pay us back $1 million for XYZ. If you've already mitigated the issues, that really puts you in good stead. Max?
No, I couldn't agree with you more. And I don't know that I could add a lot to what Deborah said. The short answers are clearly what she said. I know we're bumping up on time limits here, but so I would totally agree. I think sometimes it's kind of like the IRS calling, we think the sky's falling and we have to hop to, and just certainly you do. You don't just overlook IRS or OIG or whomever calling, even the state agencies. But I think there's a time and a place. And obviously, if you have some doubts, you should get good counsel from Garfunkel Wild is who I would call.
Thank you, Max. I'll be sending you that check.
I appreciate that. Yeah, I need it.
So okay, look, we're way over time. Couple of closing thoughts. One is we're going to be sending you a survey about whether we should remain virtual or not. I heard today that, COVID infections in the United States is down 52%. So I love it. Okay. Question is, like Lillian and Monica said, we learned a lot of lessons, and I don't know, maybe we keep doing this, but you guys are going to decide. I think Greg's point was right. Support your associations because these are tough times. It's all going to be posted to YouTube channels, and I'm going to be asking in a separate email to the speakers if they would like us to share their contact information. I know some people might not want to necessarily get all these questions, some would. So to the ones who will share, we will be sending you their contact information. And thank you guys so much. Our community keeps growing. This year was the biggest one we've ever had in 8 years. So stay healthy, stay sane, and God bless. Take care.
Thank you.
Thank you,
Thanks a
Andrew.
lot.
Thank you.
Thank you.
Bye.
Thank you very much.